Welcome to the Deep Dive. Today we're taking a deep dive into musculoskeletal problems, a topic, well, absolutely essential for any nursing student. You know how dense those textbooks can be, right?
Yeah.
But our mission today is really to cut through the noise, extract those vital nuggets of knowledge from Lewis's medical surgical nursing, and just make the complex clear and memorable for you.
Exactly. We're talking about conditions that directly impact a patient's ability to move, manage pain, and stay safe. Really core concepts.
That you'll see every day.
Every single day in practice, yeah. From the underlying causes, the pathophysiology, to identifying symptoms, and, most importantly, knowing what to do as a nurse. This deep dive should equip you with essential insights for your studies and your future career.
Think of this as your personalized shortcut through the chapter. We want to make sure you grasp not just what these problems are, but really why they matter to your patients. So let's unpack this.
All right.
We're kicking things off with osteomyelitis. It's a severe infection of the bone itself, its marrow, and even the surrounding soft tissue. Yeah, it's serious stuff.
And it's most commonly caused by a bacterium called Staphylococcus aureus, though I guess other pathogens can be involved too.
Oh, definitely. But Staph aureus is the big one. What's fascinating here, though, is understanding how these tenacious microorganisms actually invade. We generally see two main pathways.
Okay.
First, there's indirect entry, sometimes called hematogenous. That means it spreads through the bloodstream.
So from somewhere else in the body.
Exactly. This accounts for maybe 20% of cases. It often affects children, but in adults, it's more common in those who are older, maybe debilitated on hemodialysis, have sickle cell disease, or use IV drugs.
And where does it usually land in adults?
The vertebrae are a frequent target in adults, yeah.
So that's an internal invasion, kind of an inside job, you could say. But what about when the outside world directly breaches the bone?
Right, that's the other pathway. Direct entry or contiguous. And it's far more common, like 80% of cases, usually affecting adults.
Okay, how does that happen? Well, it happens when an open wound, think maybe a penetrating injury, a fracture, or even surgery, allows multiple types of microorganisms to just enter directly into the bone. It can also be related to foreign bodies, like orthopedic implants or prostheses.
Like a hip replacement.
Exactly, or even chronic ulcers, especially in patients with diabetes or vascular disease.
So once these invaders are in, what happens inside that, well, pretty rigid bone structure?
Right, that rigidity is key. Microorganisms grow rapidly, and because the bone can't expand, pressure just builds up inside.
Yeah.
This pressure leads to ischemia, it cuts off the vital blood supply, and ultimately the bone tissue dies. That dead bone is what we call sequestra.
And this is where it gets really insidious, isn't it? The body's own defense can actually complicate things.
Precisely. The body tries its best, tries to wall off the infection by forming new bone, called involucrum, around that dead sequestra.
So it's like building a wall around the problem.
Yeah, but it creates a kind of fortress for the bacteria. Antibiotics and even the body's own white blood cells really struggle to penetrate this dead, walled-off bone.
So the sequestrum just sits there.
It becomes a persistent reservoir for infection, yeah. If it's left untreated, a sinus tract can develop, leading to chronic drainage out through the skin.
In chronic osteomyelitis, that scar tissue makes it even harder.
Absolutely. That scar tissue isn't just a sign of long-term infection. It actively creates an environment where antibiotics just can't get in effectively. So systemic symptoms might quiet down, but the local destruction can continue pretty stealthily. It's a really persistent, frustrating battle.
Wow. So how do we spot this battle raging inside the bone? What are the key signs and symptoms we should be looking for?
Well, the symptoms really depend on whether it's acute or chronic. With acute osteomyelitis that's present for less than a month, you'll typically see intense, constant bone pain. It often worsens with activity and isn't relieved by rest.
That sounds pretty specific.
It is. And you'll also see swelling, tenderness, warmth at the site, and restricted movement of the affected limb. Systemic signs are usually quite pronounced too. Fever, night sweats, chills, restlessness, nausea, and just a general feeling of malaise.
Okay, and chronic?
With chronic osteomyelitis, which lasts over a month, it just hasn't responded to treatment, the systemic signs often lessen. People might not feel generally sick anymore, but the local issues persist. That constant bone pain, the swelling, and the warmth at the site are still there.
Got it. And for diagnosis, what's definitive? What really tells us it's osteomyelitis?
A bone or soft tissue biopsy is the definitive way to identify the exact causative agent, the specific bug.
Makes sense. You need to know what you're fighting.
Exactly.
Yeah.
Blood and wound cultures are also vital. Lab tests often show an increased white blood cell count, an elevated erythrocyte sedimentation rate, the ESR, and high C-reactive protein, or CRP. These indicate inflammation.
What about imaging? Can we see it on an X-ray?
Eventually, yes, but x-rays might not show changes for like 2 to 4 weeks, so they aren't great for early diagnosis. CT scans are better for assessing the infection's extent, and MRI is really excellent for early detection of bone marrow edema, which happens pretty early on.
Okay, MRI is key for early detection then.
Yeah, definitely helpful. Radionuclide bone scans and WBC scans can also pinpoint early abnormalities.
Once it's diagnosed, how is this severe infection managed? It sounds tough to treat.
It can be. Interprofessional care for acute osteomyelitis primarily involves prolonged antibiotic therapy, often starting intravenously for, say, 4 to 6 weeks, but sometimes much longer, up to 3 to 6 months, even before potentially switching to oral antibiotics.
Wow, that's a long time on antibiotics.
It is, and getting those cultures before starting any drugs is absolutely vital. You need to target the right organism.
Makes sense.
Patients might even go home with a central venous access device, a CVA, like a PICC line for continued IV antibiotics.
It's a home IV therapy.
Yep. For chronic osteomyelitis, it often requires surgery. Surgical removal of the dead bone, the sequestra, and any poorly perfused tissue is key, followed by extended antibiotics. Sometimes surgeons implant acrylic beads containing antibiotics right into the space.
Interesting.
Advanced wound care techniques like negative pressure wound therapy or wound vacs are often used too. And sometimes hyperbaric oxygen therapy can help for really stubborn cases.
And if there's an implant involved?
If an orthopedic prosthetic device is the source of the infection, it almost always has to be removed.
Oh, wow. So that means another major surgery.
Often, yes. And in really severe, extensive cases, amputation might unfortunately be necessary to improve quality of life or even save the patient's life.
That's drastic. As nurses, our role sounds absolutely crucial here. What are the key assessments and interventions we need to focus on?
Absolutely critical. When we assess a patient, we're looking to gather both subjective and objective data, much like the comprehensive approach in your nursing texts. Subjectively, we'd ask about their health history, any trauma, open wounds, other infections, medication use, and we note symptoms like malaise, anorexia, chills, local tenderness, increased pain with movement.
Okay. And objective.
Objectively, we might observe restlessness, high fever, night sweats, maybe they're guarding the limb, restricted movement, any wound drainage, redness, warmth, edema at the site. Our planning then focuses on managing that pain and fever, preventing complications like fractures or contractures, and ensuring they stick to that long treatment plan.
Right. Adherence is key with those long antibiotic courses.
Totally. For implementation, we prioritize health promotion first. That means controlling existing infections like UTIs or pressure injuries to prevent osteomyelitis from even starting. We also need to educate at-risk patients.
Who would be considered at risk?
People who are immunocompromised, those with diabetes, or patients with orthopedic implants. We teach them the signs to watch for: bone pain, fever, swelling, restricted movement, and tell them to report those to their healthcare provider promptly.
Okay, and in the acute care setting?
In acute care, we often need to immobilize the affected limb, maybe with a splint or traction. This decreases pain and helps prevent injury, like a pathologic fracture. We have to handle that limb very carefully.
Gentle handling, got it.
And we rigorously assess and manage pain. That might involve NSAIDs, non-steroidal anti-inflammatory drugs, or opioids, or maybe muscle relaxants if there's spasm. Proper dressings are important too. Could be dry, sterile, wet to dry, or negative pressure, and disposing of them correctly prevents spreading infection.
What about mobility?
Well, promoting bed rest initially is common, but good body alignment and frequent position changes are vital to prevent complications like flexion contractures or foot drop.
And those long-term antibiotics. Any nursing implications there?
Oh, absolutely. We must educate patients on potential adverse reactions to prolonged high-dose antibiotics. Things like hearing problems from aminoglycosides, renal dysfunction, neurotoxicity. We need to monitor peak and trough levels for certain drugs like vancomycin and watch for superinfections, fungal infections like thrush or Clostridioides difficile, C. diff colitis.
That's a lot to monitor. And I imagine it's stressful for the patient too.
Definitely. Providing emotional support for anxiety is a big part of our role.
Once they're home, how do we support them through this long process?
Right, ambulatory care. Teaching patients and their caregivers how to manage the CVA, if they have one, and administer antibiotics at home is critical. We really have to emphasize the importance of completing the entire course, even if they start feeling better.
Yeah, that's a common challenge.
It is. We also provide instructions and supplies for dressing changes if they have an open wound. And for chronic osteomyelitis, it really requires ongoing physical and psychological support. It can be a long, hard road.
Definitely sounds challenging. Okay, so from infection, let's shift focus a bit to another type of cellular disruption, abnormal bone growth, where the body's own cells kind of turn rogue and form tumors. Now, you mentioned primary bone tumors are rare, right?
That's right. Primary bone tumors, ones that start in the bone, are actually quite rare in adults. But the spread of cancer to the bone, metastatic bone cancer, is unfortunately a much more frequent and significant challenge we see.
Let's start with benign tumors then.
Okay. Benign tumors are far more common than primary malignant ones. The most common benign type is an osteochondroma. It's basically an overgrowth of cartilage and bone, usually found near the growth plates of long bones or in the pelvis or scapula.
Is it usually painful?
Typically, it presents as a painless, hard mass. It might cause soreness or pressure on nerves if it gets large. Diagnosis is usually straightforward with imaging like X-ray, CT, or MRI. Surgical removal is mainly done if it's causing symptoms or if there's concern about it potentially becoming malignant, which is rare.
Okay. Now, onto the more aggressive side. Malignant bone tumors, or sarcomas.
Right. The most common primary bone cancer is osteosarcoma. This is a very aggressive cancer, and it spreads rapidly. It often starts in the pelvis or the metaphysis, the wider part at the end of long bones, like the distal femur near the knee or the proximal tibia.
And who usually gets this?
It's most common in children and young adults, unfortunately. Manifestations usually include a gradual onset of pain and swelling, often worse at night. Diagnosis is confirmed by a tissue biopsy. Labs might show increased serum alkaline phosphatase and calcium, and various imaging studies are used.
How is osteosarcoma treated? It sounds aggressive.
It is. Treatment often involves neoadjuvant chemotherapy first to try and shrink the tumor before surgery. Then surgery is performed, often a limb salvage procedure if clear margins can be achieved, trying to save the limb. But sometimes amputation is necessary. After surgery, there's more chemotherapy, called adjuvant chemo. This combination approach has significantly increased the 5-year survival rate.
That's good news. Now, what about the cancer that starts somewhere else, like the breast or lung, and then travels to the bone?
Right, that's metastatic bone cancer, and as we said, it's vastly more frequent than primary bone cancer. Common primary sites that spread to bone include breast, colon, prostate, lungs, kidney, and thyroid.
How do the cells get there?
These cancer cells travel through the lymph system and the bloodstream, and they often lodge in the spine, ribs, or pelvis.
And what are the big complications we worry about with metastatic bone cancer?
A major complication is pathologic fractures. The bone is weakened by the tumor, making it susceptible to breaking with minimal or no trauma. High serum calcium levels, hypercalcemia, are also common, as the damaged bone releases calcium into the bloodstream.
How do we detect these metastatic lesions?
Bone scans are crucial for early detection. They can pick up metastatic lesions sometimes even before they cause symptoms. Treatment for metastatic bone cancer is often palliative, meaning it focuses on relieving symptoms and improving quality of life rather than cure. This often involves radiation therapy to shrink tumors and relieve pain, and meticulous pain management.
As nurses, how do we manage patients with either primary or metastatic bone cancer?
Our nursing care really mirrors a lot of general cancer care principles. We need to vigilantly monitor the tumor site for swelling, any changes in circulation, decreased movement, or sensation changes below the tumor.
And preventing those pathologic fractures sounds key.
Absolutely paramount. This means extremely careful handling of extremities. Use support when turning. Log rolling patients with spinal involvement is essential to maintain alignment. We also manage hypercalcemia if it occurs, encourage activity as tolerated but balanced with rest periods, and rigorously assess and manage pain, which can be quite severe, especially if the tumor is pressing on nerves.
And the psychological aspect.
Huge. Emotional support is vital, and patient education on chemotherapy side effects, radiation therapy, and postoperative care, depending on their treatment plan, is essential.
Okay. Next up, let's dive into muscular dystrophy, or MD. This is a group of genetic diseases, right? Not just about muscle weakness.
Exactly. It's not just weakness, it's about progressive symmetric wasting of skeletal muscles. Importantly, there isn't primary neurologic involvement. The nerves are okay, but the muscles themselves degenerate. This leads to increasing disability and deformity over time.
And the key is the genetic basis.
Yes, the genetic basis is fundamental. Duchenne MD is the most common and severe form. It's an X-linked recessive disorder, meaning it primarily affects boys.
When does it usually show up?
Onset is typically before age 5. It leads to progressive weakness, starting often in the pelvic and shoulder muscles. Kids might have trouble running, jumping, climbing stairs. Sadly, many are unable to walk by age 12.
And it affects more than just limb muscles.
Yes, critically, it often involves cardiomyopathy affecting the heart muscle and respiratory muscle weakness, leading to respiratory failure later on.
What's the underlying genetic cause?
It's caused by mutations in the DMD gene, which codes for a protein called dystrophin. Dystrophin is vital for maintaining the structural integrity of muscle fibers. Without it, the muscle cells are easily damaged and break down.
How is it diagnosed?
Diagnosis involves several things. Muscle serum enzymes, particularly creatine kinase, CK, are usually very high because they leak out of damaged muscle cells. An electromyogram, or EMG, shows muscle dysfunction. A muscle biopsy is often definitive, showing characteristic changes like fat and connective tissue deposits replacing muscle fibers, and specifically, a deficiency or absence of dystrophin. Genetic testing confirms the specific mutation, and an ECG is important to check for that cardiomyopathy.
Is there a cure for MD?
Unfortunately, no cure currently exists.
Sure.
Treatment goals are really focused on preserving mobility and independence for as long as possible and managing complications.
What kind of treatments help?
Corticosteroids, like deflazacort, can slow the progression of muscle weakness for a time. And recently, specific disease-modifying drugs, like eteplirsen, have emerged that target certain gene mutations, though they only work for a subset of patients.
So what's our role as nurses in caring for these patients?
Our role is really supportive and focused on maximizing function and quality of life. We encourage exercise, physical therapy, and the use of assistive devices like braces or wheelchairs to help maintain activity. We need to help manage the complications.
Like the spine and breathing issues.
Exactly.
Yeah.
Spinal collapse can occur, requiring orthotic jackets for support, and we monitor respiratory function closely, managing decline with interventions like CPAP, and eventually, sometimes a tracheostomy is needed for ventilation.
Is activity restriction ever needed?
Actually, avoiding prolonged bed rest is crucial, as inactivity leads to further muscle wasting. Our nursing care emphasizes teaching range of motion exercises to prevent contractures, ensuring good nutrition, helping the patient and family recognize signs of disease progression, and providing vital emotional support. It's a challenging diagnosis for everyone involved. Resources like the Muscular Dystrophy Association are invaluable for families.
Okay. Now let's move to a problem that almost everyone experiences at some point.
Oh.
Low back pain. You mentioned it affects about 80% of adults.
Yeah, it's incredibly common, and it's a leading cause of job-related disability and missed work days.
Why is the lower back so vulnerable?
Well, the lumbar region of the spine bears most of the body's weight. It's also highly flexible, which is good for movement, but it means it's susceptible to strain. Plus, it contains nerve roots that are vulnerable to injury or compression.
And the pain itself can present differently.
Right. Low back pain can be localized, just felt in the back, or diffuse. It can be radicular, which means it radiates along the path of a nerve root, like sciatica down the leg. Or it can be referred pain, originating from another site like the kidneys or abdomen, but felt in the back.
What puts someone at higher risk for low back pain?
Several things. Poor muscle tone, especially weak core muscles. Obesity adds extra strain. Trauma, obviously. Poor posture, both standing and sitting. Older age brings degenerative changes. Smoking affects circulation to the discs. Pregnancy shifts the center of gravity. And jobs requiring heavy lifting, vibration, or prolonged sitting are also big risk factors.
What are the common underlying causes?
It ranges quite a bit. Could be an acute lumbosacral strain or sprain, osteoarthritis of the spine, degenerative disc disease, or a herniated disc pressing on a nerve.
Let's try to distinguish between acute and chronic pain. What about acute low back pain? How long does that last?
Acute low back pain is defined as lasting 4 weeks or less. It's often caused by some kind of trauma or activity that overstresses the lower back, like lifting something heavy the wrong way or maybe a fall.
And the symptoms?
They can range from a dull muscle ache to a sharp shooting or stabbing pain. Sometimes symptoms don't appear immediately, but maybe within 24 hours, as inflammation and edema develop and put pressure on nerves. Diagnosis often relies mostly on the history and a physical assessment. The straight leg raising test is a classic maneuver. If raising the straightened leg causes pain down the leg, it suggests nerve root irritation.
Do people with acute back pain usually need scans like MRI?
Not typically, unless there's suspicion of serious trauma, like a fracture or systemic disease like cancer or infection is suspected. For most acute, uncomplicated back pain, imaging isn't needed right away.
Okay. And how is that acute phase usually managed?
For mild to moderate pain, it's usually outpatient treatment. NSAIDs, nonsteroidal anti-inflammatory drugs, are often first line. Muscle relaxants can help if there's spasm. Things like massage, acupuncture, and using hot or cold compresses can provide relief too.
What about opioids?
For severe pain, a short course of corticosteroids or opioids might be needed, but the goal is to use them sparingly and briefly due to addiction potential and side effects.
And rest. Should people stay in bed?
We used to recommend prolonged bed rest, but now we know better. We encourage maybe brief rest for 1 to 2 days if the pain is severe, but then a gradual return to regular activities as tolerated, avoiding movements that clearly worsen the pain. Most cases of acute low back pain actually improve significantly within about 2 weeks.
Beyond just getting through the acute phase, preventing it from happening again seems really important, doesn't it?
Absolutely. Preventing recurrence is key. We spend a lot of time teaching patients about proper body mechanics.
Like what specifically?
Things like maintaining a healthy weight to reduce strain, using proper posture when standing or sitting, avoiding slouching. A big one is bending at the knees, not the waist, when lifting heavy objects, and keeping the object close to the body. Regular exercise, especially strengthening the core, abdominal, and back muscles, provides stability.
Anything else for prevention?
Yes, smoking cessation is vital because smoking decreases blood flow to the spinal discs. We also advise against sleeping prone on the stomach as it stresses the back. Sleeping on the side or back with pillows for support is better, and a firm mattress generally provides better support.
Are there programs for this?
Yeah, patient education programs, sometimes called back school, are excellent for teaching these prevention strategies and exercises. And for us as nurses, modeling proper body mechanics ourselves is crucial to prevent work-related back injuries, which are unfortunately common in healthcare.
Good point. Okay, so what defines chronic low back pain?
Chronic low back pain is generally defined as pain that lasts longer than 3 months or involves repeated incapacitating episodes.
And the causes? Are they different from acute pain?
Often they are, or they're more complex and harder to pinpoint. Causes can include degenerative conditions like osteoarthritis or degenerative disc disease, osteoporosis leading to compression fractures, weakness from old injuries, chronic strain from poor posture or mechanics over time, or even congenital spine problems.
You mentioned spinal stenosis earlier. Can you explain that?
Right. Spinal stenosis is a significant cause of chronic low back pain, especially in older adults. It's a narrowing of the spinal canal, the space where the spinal cord and nerve roots run.
What causes the narrowing?
It's often due to osteoarthritis, bone spurs growing into the canal, or thickened ligaments or bulging discs. This narrowing compresses the nerve roots.
What does the pain feel like with stenosis?
Pain typically radiates down into the buttock and leg, often described as numbness, tingling, or heaviness. Interestingly, it often gets worse with walking or prolonged standing, but may improve when the person bends forward or sits down as that posture opens up the spinal canal a bit.
How do we manage this persistent chronic low back pain?
Management strategies overlap with acute pain, but they're often longer term and may require a multidisciplinary approach. Mild analgesics like acetaminophen or NSAIDs are used for pain and stiffness. Sometimes antidepressants like duloxetine or anti-seizure drugs like gabapentin can help with the nerve-related pain components.
What about non-drug approaches?
Weight reduction if needed, regular rest periods throughout the day, and physical therapy focusing on strengthening and flexibility are crucial. Complementary therapies can also play a role. Things like biofeedback, acupuncture, yoga, or tai chi might help some people manage their pain.
Are there more invasive options if those don't work?
Yes, minimally invasive procedures like epidural corticosteroid injections can provide temporary relief by reducing inflammation around the nerve roots. For some, implanted pain devices that deliver electrical stimulation or medication might be considered. And finally, surgery might be an option for severe intractable pain or if there are significant neurological deficits like progressive weakness.
Okay, let's talk more about those discs. Our spine's shock absorbers, the intervertebral discs, can cause significant problems when they degenerate or herniate.
That's absolutely right. Degenerative disc disease, or DDD, is a really common process, almost a normal part of aging for many people. As we age, the discs lose their fluid content, their elasticity, and their shock-absorbing ability.
What happens inside the disc?
The nucleus pulposus, that's the gelatinous center of the disc, starts to dry out and shrink. This means load isn't distributed as well, putting more pressure on the outer layer, the annulus fibrosus, which can then develop cracks or tears.
And that leads to a herniated disc.
It can, yes. A herniated disc, sometimes called a slip disc or ruptured disc, occurs when that nucleus pulposus actually seeps out through a tear in the annulus. If it pushes backward into the spinal canal, it can press on spinal nerves.
And that pressure on the nerve causes.
That causes radiculopathy, that radiating pain, numbness, tingling, or weakness along the path of the compressed nerve.
Where do herniated discs most commonly occur?
The most common sites are the lumbosacral spine, particularly between L4 and L5, or L5 and S1, because that area bears a lot of weight and movement. The cervical spine is the next most common site, especially C5-6 or C6-7.
What are the specific clinical manifestations we'd see? Let's start with the lumbar spine.
Okay, for lumbar disc disease, the most common symptom, unsurprisingly, is low back pain. If there's nerve root compression, you get that radicular pain, often radiating down the buttock and below the knee, typically along the sciatic nerve path.
And the straight leg raise test.
Yep, a positive straight leg raising test often indicates nerve root irritation here. Reflexes in the leg, like the knee jerk or ankle jerk, might be depressed or absent, and patients may report numbness, tingling, or muscle weakness in the legs, feet, or toes, depending on which nerve root is affected.
You mentioned an emergency earlier related to this.
Yes, a critical medical emergency to watch for is cauda equina syndrome. This is caused by compression of multiple lumbar and sacral nerve roots, often by a large central disc herniation.
What are the signs of that? Sounds serious.
It is very serious. Symptoms include severe low back pain, progressive weakness in the legs, problems with bowel or bladder function, either incontinence or retention, and something called saddle anesthesia, which is altered sensation or numbness in the area where you'd sit on a saddle. The perineum, buttocks, inner thighs, and back of the legs. This requires immediate surgical decompression to prevent permanent paralysis and loss of bowel bladder function.
Wow, okay, definitely something to watch for. What about cervical disc disease? How does that present?
In the neck, pain often radiates into the arms and hands, following the affected nerve root. Hand grip might be weak. It's important to rule out shoulder problems too, as they can sometimes mimic cervical radiculopathy.
How is disc disease diagnosed?
Diagnosis usually starts with a history and physical exam. X-rays can show structural changes like DDD or stenosis, but MRI is usually the best imaging test to visualize the discs, nerve roots, and any herniation or compression. CT scans or a myelogram might also be used, and sometimes EMGs are done to assess the electrical activity of the nerves and muscles and pinpoint nerve irritation.
Treatment often starts conservatively, right? You don't jump straight to surgery.
Exactly. For most patients, conservative therapy is the first step and is often successful.
What does that involve?
It usually includes limiting spinal movement for a short period, maybe with a brace or corset. Applying local heat or ice can help with pain and inflammation. Physical therapy is key exercises to strengthen supporting muscles and improve posture. Sometimes traction is used. 10 NS units, transcutaneous electrical nerve stimulation, might provide some pain relief, and drug therapy is common.
What kinds of drugs?
Usually NSAIDs first, maybe corticosteroids for inflammation, short-term opioids if pain is severe, muscle relaxants for spasms. Sometimes those anti-seizure drugs or antidepressants for neuropathic pain. Epidural corticosteroid injections directly around the nerve root can also be very effective in reducing inflammation and pain.
And the goal is symptom relief.
Yes, and allowing the body to heal. Once symptoms subside, lifelong attention to back strengthening exercises and proper body mechanics is crucial to prevent recurrence. The good news is that most patients with a herniated disc improve significantly within 6 months with conservative treatment.
But when conservative treatment fails, or if there's severe nerve compression like cauda equina syndrome, surgery might be needed. What are the general options there?
Right. If conservative treatment isn't enough, surgery aims to decompress the pinched nerve root and/or stabilize the spine. There are several approaches.
Like minimally invasive ones.
Yes, there are minimally invasive options. Things like intradiscal electrothermoplasty, IDET, use heat to destroy nerve fibers in the disc and toughen the annulus. Radiofrequency discal nucleoplasty uses radio waves to remove some of the nucleus, decompressing the disc. And interspinous process devices are small implants placed between vertebrae to lift them off a pinched nerve, often used for stenosis.
What about more traditional surgeries?
The most common surgery for a herniated disc is a laminotomy with discectomy. The surgeon removes a small portion of the lamina part of the vertebra to access the disc, and then removes the herniated portion that's pressing on the nerve.
Is that usually open surgery?
It can be, or it can be done minimally invasively using a microscope, microdiscectomy, or a tiny camera, endoscopic microdiscectomy. These usually mean smaller incisions and faster recovery.
What if the disc itself is the main problem, like in severe DDD?
For some patients with severe DDD, artificial disc replacement is an option. A device is surgically implanted to replace the damaged disc, aiming to restore movement and eliminate pain.
And what if the spine is unstable?
If the spine is unstable, perhaps due to removing a lot of disc material or from the underlying condition, then spinal fusion might be necessary. This involves fusing adjacent vertebrae together so they heal into one solid bone.
How's that done?
It usually involves using a bone graft, either an autograft from the patient's own hip or an allograft from a donor placed between the vertebrae. Often, metal hardware like rods, plates, or screws is used for immediate stability while the bone graft heals and fuses. There are different approaches from the back, PLIF, the front, ALIF, or the side, TLIF, XIF. Sometimes a special protein called bone morphogenetic protein, BMP, is used to stimulate bone growth in the graft area.
Okay, lots of surgical options. Post-surgery, nursing care sounds absolutely critical. What are the priorities?
Hugely important. A key focus immediately after spinal surgery is maintaining proper spinal alignment. This means careful log rolling the patient as one unit, avoiding twisting, and using pillows for support when positioning.
Pain management too, I assume.
Paramount. Pain management is crucial, often starting with IV opioids via PCA pump initially, then transitioning to oral meds. We must also vigilantly monitor for potential complications. One serious one is cerebrospinal fluid CSF leakage.
How would we spot that?
Look for clear or slightly yellowish drainage from the surgical site or the patient complaining of a severe headache, especially when upright. If the drainage tests positive for glucose, that confirms it's CSF. If you suspect a CSF leak, you need to report it immediately and usually keep the patient flat in bed.
What else do we monitor closely?
Frequent neurovascular assessments of the extremities checking movement, strength, sensation, pulses, color, temperature are essential. Compare these findings to the patient's preoperative status and report any new weakness or paresthesia immediately, as it could indicate nerve damage or swelling. We also need to manage bowel and bladder function. Paralytic ileus and constipation are common after back surgery due to anesthesia and opioids, and urinary retention can also occur.
Any specific concerns after cervical spine surgery?
Yes, after neck surgery, we monitor closely for signs of spinal cord edema, which could compromise breathing. Watch respiratory rate and effort, oxygen saturation. Be prepared for potential airway issues.
And if a spinal fusion was performed?
If a fusion was done, the healing time is longer, often 3 to 6 months or more. This usually means activity limitations, like restrictions on bending, lifting, and twisting. The patient might need to wear a rigid orthosis, like a TLSO brace. We need to ensure correct application and check the skin underneath frequently for breakdown. Interestingly, the donor site for the bone graft, often the iliac crest of the hip, can sometimes be more painful than the actual fusion site.
Good to know. And patient education.
Crucial for long-term success. Teaching proper body mechanics, reinforcing activity restrictions, especially no twisting movements, and advising patients to avoid prolonged sitting or standing are vital parts of discharge planning.
Okay. Just like the lower back, our neck is vital for mobility and can be a common source of significant pain.
Very common, yes. Neck pain can range from benign things like simple cervical strains or sprains, often from hyperflexion hyperextension injuries like whiplash in a car accident, to more serious conditions like spondylosis, arthritis, disc herniation, stenosis, or even fractures.
What are the symptoms?
Patients usually report stiffness and pain in the neck. If there's nerve root compression, they might experience radicular pain radiating into the arm and hand, or weakness, numbness, or paresthesia, tingling, in that distribution. Diagnosis involves a thorough history, physical exam focusing on neck movement and neurological function in the arms, and usually imaging like X-ray, MRI, CT, or maybe a myelogram or EMG if nerve involvement is suspected.
How is neck pain typically treated?
Similar to low back pain, conservative treatment is usually the first approach for acute neck pain. This often includes physical therapy, home exercises focusing on range of motion and strengthening, possibly gentle traction, and maybe tenons or acupuncture for short-term relief.
What about medications?
Drug therapy typically starts with acetaminophen or NSAIDs. Opioids might be used for short periods for severe intractable pain, but usually aren't needed long-term. Muscle relaxants can help if there's spasm. The good news is that most episodes of uncomplicated neck pain resolve within about 2 months without needing surgery. Patient teaching is really vital for self-management, encouraging an active lifestyle, proper posture, especially with computer use, and using supportive pillows for sleeping can help prevent recurrence.
Right. Moving down the body now. Our feet are incredibly complex structures that support our entire body weight.
Yeah.
Problems here can drastically impact mobility and quality of life.
Indeed, they can. Foot problems can arise from lots of things. Congenital conditions, structural weaknesses, injuries, or systemic conditions like diabetes and rheumatoid arthritis, which often affect the feet. But a huge culprit, honestly, is ill-fitting shoes.
Shoes, really?
Absolutely. Shoes that are too tight, too narrow, have high heels, or lack support contribute significantly to many common foot problems. Think about conditions like hallux valgus, which most people know as a bunion.
Ah, yes, the bump on the big toe joint.
Exactly. It's a painful deformity where the great toe deviates towards the other toes. Another common one, especially linked to tight shoes, is Morton neuroma. This involves a thickening of nerve tissue, usually between the third and fourth toes. It causes sharp, burning pain in the ball of the foot, sometimes with numbness or tingling in the toes. Patients often describe it as feeling like a sock is rolled up or walking on a marble.
So what's our role as nurses in managing these common foot problems?
Well, it often starts with health promotion. We really need to emphasize the importance of properly fitted, supportive footwear. Shoes should allow the toes to move freely, have adequate cushioning, and a firm sole or shank for support. We should educate patients, maybe especially women who might prioritize fashion over comfort, about the long-term consequences of poor footwear choices.
What about acute care?
Many specific foot problems require diagnosis and treatment by a podiatrist. Conservative therapies are usually tried first, things like NSAIDs for pain and inflammation, ice, physical therapy, stretching exercises, wearing wider shoes, using orthotics or padding in the shoes, or maybe corticosteroid injections for conditions like Morton's neuroma or plantar fasciitis.
And surgery is needed, say, for a severe bunion.
If surgery is necessary, post-operative nursing care involves managing pain, preventing infection, and often requires a period of immobilization with dressings, special casts, or platform shoes to keep weight off the area. Elevating the foot to reduce swelling is important, and frequent neurovascular assessment of the toes, checking circulation, sensation, and movement is crucial. We also teach safe emulation with assistive devices like crutches or a walker, ensuring they know the correct weight-bearing restrictions.
What about ongoing care, especially for high-risk patients?
Ambulatory care and patient teaching are crucial for preventing complications. We teach principles of daily hygienic foot care. Washing and drying feet thoroughly, especially between the toes, wearing clean, well-fitting socks or stockings, avoiding constricting types, and trimming toenails straight across to prevent ingrown nails.
This sounds especially important for patients with diabetes.
Critically important. For patients with impaired circulation, like those with peripheral vascular disease, or decreased sensation, like those with diabetic neuropathy, daily foot inspection is non-negotiable. They or caregiver need to inspect all surfaces of their feet every day, looking for any skin breaks, blisters, redness, or swelling, and report any concerns immediately to their healthcare provider. This vigilance is key to preventing severe complications like non-healing ulcers, infection, osteomyelitis, and ultimately amputation.
Are there specific considerations for older adults regarding foot problems?
Absolutely. Older adults are particularly prone to foot problems due to factors like poor circulation, decreased sensation from neuropathy, arthritis limiting joint mobility, difficulty reaching their feet for proper care, and sometimes vision impairment making inspection difficult. That daily foot inspection by the patient or caregiver is exceptionally important in this population to catch any issues early before they become major problems.
That patient story about the hip fracture from coughing really highlights fragility.
It really does. It underscores how important gentle handling and fall prevention are, especially with metabolic bone diseases.
Okay, perfect segue. Finally, let's delve into those metabolic bone diseases. These are conditions where normal bone metabolism, the balance between bone breakdown and formation, is disrupted. This leads to a generalized reduction in bone mass and strength throughout the skeleton. We're talking about osteomalacia, osteoporosis, and Paget disease.
Right. Let's start with osteomalacia. Think soft bones. This is caused by a deficiency of vitamin D. Vitamin D is essential for absorbing calcium from the gut. Without enough vitamin D, the body can't properly mineralize newly formed bone, so the bones become soft, weak, and painful.
What puts someone at risk for vitamin D deficiency?
Several things. Limited sun exposure is a big one, as sunlight helps our skin produce vitamin D. GI malabsorption issues like celiac disease or after bariatric surgery, chronic diarrhea, chronic liver or kidney disease, as these organs are involved in activating vitamin D. Certain medications can interfere with vitamin D metabolism too.
What are the signs and symptoms of osteomalacia?
The main symptoms are diffuse bone pain, often worse at night, and particularly affecting the lower back, pelvis, hips, legs, and ribs. Muscle weakness, especially in the proximal muscles, making it difficult to walk or get up from a chair, is also common. Patients might have a waddling gait. Over time, progressive bone deformities can occur, like bowing of the legs.
How is it diagnosed?
Diagnosis involves blood tests. We typically see decreased serum calcium and phosphorus levels, low serum vitamin D levels, and usually an increased serum alkaline phosphatase level, as the body tries to compensate by increasing bone turnover. X-rays might show generalized bone demineralization or specific findings called looser transformation zones, which look like pseudofractures.
And the treatment, is it just giving vitamin D?
Primarily, yes. Treatment focuses on correcting the vitamin D deficiency with supplements, often high doses initially. Calcium and sometimes phosphorus supplements might also be needed. Encouraging dietary intake of calcium and vitamin D fortified foods, safe sun exposure, and weight-bearing exercise to stimulate bone strength are also important parts of management.
Okay, now let's move to the really common one, osteoporosis, often called the silent thief, right?
Exactly. It's called that because bone loss occurs gradually and without symptoms until a fracture occurs. Think of healthy bone like dense scaffolding. In osteoporosis, that scaffolding becomes thin and porous, losing its structural integrity. It's a chronic, progressive metabolic bone disease characterized by low bone mass and microarchitectural deterioration of bone tissue, leading to increased bone fragility and susceptibility to fractures.
Why is it so much more common in women?
Several reasons contribute. Women generally have lower calcium intake than men throughout their lives. They tend to have less bone mass to begin with. Bone resorption starts accelerating at menopause due to the decline in estrogen, which normally helps protect bone density. And women typically live longer than men, allowing more time for bone loss to accumulate. That's why initial bone density screening, usually with a DEXA scan, is recommended for all women over 65 and earlier for those with risk factors.
What are the key risk factors we should know, besides being female and older?
There are quite a few. Advancing age is a major one for both sexes. Ethnicity plays a role. White and Asian individuals are at higher risk. A family history of osteoporosis increases risk. Lifestyle factors are huge. Low dietary intake of calcium and vitamin D, excessive alcohol consumption, more than 2 drinks a day, cigarette smoking, low body weight or small frame, and a sedentary lifestyle with insufficient weight-bearing exercise. Certain medications, especially long-term use of corticosteroids like prednisone, are notorious for causing bone loss. Low testosterone levels in men also contribute.
So what's actually happening at the cellular level in the bone?
In osteoporosis, there's an imbalance in the normal bone remodeling process. Bone resorption, the breakdown of old bone by cells called osteoclasts, exceeds new bone deposition by cells called osteoblasts. Essentially, the demolition crew is working faster than the construction crew, leading to a net loss of bone mass and strength over time.
And the clinical manifestations, besides fractures.
Often, the first sign is a fracture, frequently occurring with minimal trauma, like a fall from standing height or less. The most common sites for osteoporotic fractures are the spine, vertebral compression fractures, the hips, and the wrists. Vertebral fractures can be insidious. They might cause back pain, or they might occur gradually without acute pain, leading to a progressive loss of height and the development of a stooped posture called kyphosis, often referred to graphically as a dowager's hump.
How do we diagnose osteoporosis definitively?
Diagnosis is primarily made using bone mineral density (BMD) measurements. The gold standard test is dual energy X-ray absorptiometry, or DEXA scan, typically measuring bone density in the spine and hips.
How are the results reported? What about T-scores?
Right. The results are reported as T-scores. A T-score compares the patient's BMD to the peak bone mass of a healthy young adult of the same sex. A T-score between +1 and -1 is considered normal. A T-score between -1 and 92.5 indicates osteopenia, which is lower than normal bone density but not yet osteoporosis. A T-score of -2.5 or lower indicates osteoporosis. There's also a Z-score, which compares the patient's BMD to people of their own age, sex, and ethnicity, but the T-score is primarily used for diagnosis in postmenopausal women and men over 50.
Okay. Once diagnosed, how is osteoporosis managed? It seems like prevention and treatment overlap a lot.
They absolutely do. Management focuses on preventing further bone loss, reducing fracture risk, and managing existing fractures. Key components include
Nutrition first.
Yes, nutrition. Ensuring adequate intake of calcium is crucial. The recommendation is typically 1,000 milligrams per day for most adults, increasing to 1,200 milligrams per day for women over 51 and men over 71. Good dietary sources include milk, yogurt, cheese, sardines, fortified orange juice, and leafy green vegetables. If dietary intake isn't sufficient, calcium supplements are used. They should ideally be taken in divided doses, like 500, 600 milligrams at a time for better absorption. Calcium carbonate needs stomach acid, so take it with meals, while calcium citrate can be taken anytime.
And vitamin D.
Vitamin D is essential for calcium absorption. Many people, especially older adults and those with limited sun exposure, need vitamin D supplements to maintain adequate levels, often 800, 1000 IU/day or more, depending on their levels.
What about exercise?
Exercise is critical. Weight-bearing exercises, activities done on your feet where you bear your own weight, like walking, hiking, jogging, climbing stairs, dancing, and weight training, are most effective for stimulating bone formation. Balance exercises are also important to reduce fall risk.
Speaking of falls,
Fall prevention is a huge part of management. This involves assessing the home environment for hazards like throw rugs, poor lighting, clutter, addressing vision problems, reviewing medications that might cause dizziness or drowsiness, and recommending assistive devices like canes or walkers if needed.
are there procedures for vertebral fractures?
Yes, for painful vertebral compression fractures that don't respond to conservative treatment, minimally invasive procedures like vertebroplasty, injecting bone cement into the collapsed vertebra to stabilize it, or kyphoplasty, using a balloon to gently elevate the fractured vertebra before injecting cement, potentially restoring some height, might be considered.
And finally, drug therapy. There are specific osteoporosis medications, right?
Yes, drug therapy is often necessary, especially for those with confirmed osteoporosis or high fracture risk. The most commonly prescribed class of drugs is bisphosphonates. Examples include alendronate, Fosamax, risdronate, Actonel, ibandronate, Boniva, and zoledronic acid, reclassed given work.
How do they work? And any special instructions?
They work by inhibiting osteoclast activity, thus slowing down bone resorption or breakdown. Oral bisphosphonates have very specific administration instructions to ensure absorption and prevent esophageal irritation. Patients need to take them first thing in the morning on an empty stomach with a full glass of water, not juice or coffee, at least 30 minutes before any other food, drinks, or medications. And they must remain upright, sitting or standing, for at least 30 minutes after taking the pill.
That sounds important to remember. Any major side effects?
Esophageal irritation is the main common one if instructions aren't followed. A rare but serious side effect associated with long-term use is osteonecrosis of the jaw, ONJ, especially after invasive dental procedures. Patients should have good oral hygiene and inform their dentist they are taking a bisphosphonate. Atypical femur fractures are another rare potential risk.
Are there other types of drugs?
Yes. Other options include monoclonal antibodies like denosumab prolia, which also inhibits osteoclasts but works differently. Recombinant parathyroid hormone like teriparatide, Forteo, actually stimulates new bone formation but is usually reserved for severe osteoporosis and given by daily injection for a limited time. Selective estrogen receptor modulators, SERMs, like raloxifene, Evista, mimic estrogen's beneficial effects on bone but are less potent than bisphosphonates. Estrogen replacement therapy itself is generally not recommended solely for osteoporosis prevention anymore due to other potential health risks. Okay, one more metabolic bone disease to cover. Paget disease, also known as osteitis deformans.
What is Paget disease?
This is a chronic skeletal disorder where there's excessive bone resorption by overactive osteoclasts, followed by rapid, disorganized, and weaker bone replacement by osteoblasts. So you end up with enlarged, deformed, and structurally unsound bone in affected areas.
Where does it usually occur?
It often affects the pelvis, long bones, femur, tibia, spine, ribs, and particularly the cranium or skull. Its exact cause is unknown, but there seems to be a genetic component and possibly a viral trigger in susceptible individuals. It's more common in older adults.
What are the manifestations? Is it painful?
Manifestations can be quite insidious, or even absent. Many people are diagnosed incidentally. When symptoms occur, bone pain is the most common complaint. Fatigue can occur. If weight-bearing bones are affected, patients might develop bowing of the limbs or a waddling gait. Skull enlargement can lead to headaches, hearing loss if bones around the ear are involved, and sometimes increased head size. Pathologic fractures are a common complication because the new bone is weaker than normal. Other potential complications include arthritis and joints near affected bone, and rarely the development of bone cancer, osteosarcoma, within a pagetic lesion.
How is Paget disease diagnosed and treated?
Diagnosis is often suspected based on x-rays showing characteristic changes, enlarged, deformed bone with mixed lyticking and sclerotic areas, or markedly elevated serum alkaline phosphatase levels indicating high bone turnover. Bone scans show increased uptake in the affected skeletal areas. Treatment is usually symptomatic and supportive. The primary drug therapy uses bisphosphonates, often the same ones used for osteoporosis, but sometimes in different doses, like zoledronic acid IV, to slow down the excessive bone resorption. Calcium and vitamin D supplementation are important, and NSAIDs are used for pain management. Surgery might be needed to correct deformities or stabilize fractures.
And rounding this all out, what are the key nursing considerations for these metabolic bone diseases, especially osteoporosis and Paget disease in older adults?
For both conditions, particularly in older adults, maintaining proper nutrition, calcium, vitamin D, and continued safe physical activity are really key to slowing bone loss and maintaining function. We absolutely must use extreme caution when turning, moving, or handling these patients because of the very high risk of pathologic fractures, especially hip fractures, which can be devastating. Patient education is huge, focusing on fall prevention strategies we discussed, checking the home environment safety alert, watch for poor lighting, clutter, pets, ensuring they understand their medications, and encouraging participation in supervised exercise programs appropriate for their condition. Supporting their independence while ensuring safety is the main goal.
Wow, that was a truly comprehensive deep dive into musculoskeletal problems. Seriously, from the microscopic battles of osteomyelitis all the way to the genetic complexities of muscular dystrophy, and then the, well, incredibly widespread impact of back pain, disc issues, foot problems, and these metabolic bone diseases like osteoporosis. We covered a lot of critical ground.
We really have. And what stands out to me looking across all these conditions is how consistently the nursing process guides our care, doesn't it? Whether it's doing that careful assessment, prioritizing the right interventions like pain management, or preventing complications, or providing really tailored patient education, your role as a nurse is just central to managing these conditions effectively and improving patient outcomes, both in the hospital and long term in chronic care settings.
Yeah, it's definitely not just theory from the textbook.
Not at all. This is the foundation for your NCLEX style thinking, absolutely. But more importantly, it's the foundation for your day to day practice.
So as future nurses listening to this, you'll definitely be at the forefront of managing these conditions. Maybe something to think about is how will you use this knowledge? Not just to treat the symptoms, but to truly enhance your patient's mobility and their overall quality of life, especially given how chronic and life-altering many of these problems can be. How do you address those holistic needs?
That's a great point to ponder.
Definitely something to mull over as you continue your journey. Thank you so much for joining us for this deep dive today.